our today's session, the Eco Eswatini Hospice at Home Eco session. So we welcome everyone for joining in. We gave 5 minutes for the others to join in. We're supposed to start at 1 p.m. But we hope others will join. I will kindly ask you to introduce yourself in the chat box by writing your name and your facility and the others that you are joining with. So I would also like to acknowledge the constant support given by the Eco India team, who are so much grateful for the opportunity and the guidance and support that you are giving us. On today's session, we will focus on goal setting and advanced care planning. So may I, at this point, ask you to make sure that you mute your device. You will only unmute when you have something to say. I will also request you to make sure that your phone is on silent. You can also use the chat box if ever you have got something to ask or to say. And also, you can also raise your hand. Well, on today's agenda, we will look at, we'll have a presentation on goal setting and advanced care planning, which will be presented by Mr. Mabuza. We'll also have a case presentation from RFM Hospital Palliative Care Unit. We will also request your participation for the program to be lively and successful. We are all here to learn from such a platform. Thank you so much for joining in. We really appreciate this point in time. I will ask Mr. Mabuza to present on goal setting and advanced care planning. Thank you.
Thank you very much, Mr. Seven. And my name is Mabuza. I work as a nurse at Hospice at Home Palliative Care. Today we are going to be looking at advanced care planning in palliative care. Is everyone getting me? Or should I raise my voice? Or... Okay. Silence means golden, which means I can go ahead. Okay, let's look at the objective for our presentation. The goal is to prepare a healthcare worker to discuss and report and honor individual choices about end of life care. The second objective, to identify triggers that for discussion of advanced care planning and demonstrate the understanding of factors and influences that can affect patient choices. Then the last objective is explain the principle, effective listening and information given. Okay, the introduction will define some terms which we're going to be using or you're going to be hearing as we go through the presentation for today. The first term is advanced care planning. This is a process of discussing and reflection about goals and values and preferences for future treatment for a patient. That's advanced care planning. The second term is advanced care directives. Then here it's a document. This one, it's a document, is different from that one. About that one is a process. This one is a document where a person can write down what they would like or would not like to happen in relation to their medical treatment. And the third one is proxy decision maker. This one is a person appointed by a patient through the advanced care statement, which is the document, to make decision on behalf of the patient in relation to healthcare or treatment. Then the fourth one is durable power of attorney for healthcare. This one is a legal document. This one includes a lawyer. In this one, it's a legal document that gives power to that gives the proxy decision maker, the person appointed by the patient, which is the proxy decision maker. It gives that person power to act on behalf of the patient. This is a durable power of attorney in that document. And lastly, the living will. And again, this one is a document which allows people to state wishes, preferred priorities for healthcare if they become unable to communicate them. As we all know, that sickness at some point, you get to a stage where you cannot communicate to your relatives or to your healthcare providers. Okay, we're moving on. If you have any question, you are free to use the chat box as I continue. Then we'll address after the presentation. Okay, this one. Okay, as we have defined the terms, now we're going to look at how the flow of the advanced care planning. As we have seen, I'm not sure if the color reflects as it reflects on my side. There's a blue color, which is advanced care planning, which is here is the planning. Then it is divided into three. There is the patient, what the patient does want to happen, and which is the advanced wishes and statements, and preferred priorities for healthcare. And then there is the proxy decision maker. That's when in the advanced care planning of the patient appoints someone to speak or to make decision on the patient's behalf. Yeah, it can be divided into two, the proxy decision maker. Yeah, it cannot, it is two, it can involve a lawyer, which is the durable power of attorney. It can be written down in a statement, which is a living will that will be defined earlier in the introduction. So a proxy decision maker can exist in two different states. It can exist in a living will and can exist in a legal document which involves a lawyer, which is the durable power of attorney. Then there is the last one. This is what the patient does not want to happen, which is the advanced decision to refuse treatment. And this one again, even though it cannot include a lawyer, but at the same time, this one can be a final decision. If the patient doesn't want blood transfusion, the patient does not want blood transfusion, even though if there is no legal statement that is being brought forward. So this is the advanced decision making to refuse treatment. Okay. Then we'll go forward to principle guiding the advanced care planning. The advanced care planning, it should be upstream. It will start at every starting point, at every entry of a patient. That's where it will start. Because in case of any illnesses, the patient can, instead the patient can go to coma. It could be easy for the healthcare providers to start to communicate through the advanced care planning for the patient. So it must not be at the stage where the person is about to die. So that's when it is difficult. But you have to start it early, at an early stage, so that it could be easier. Then it should be culturally sensitive, adaptable to diverse communities, and sustainable. Continue to provide resources after initial rollout. And alignment. It will complement current programs of palliative care to patient needs. Standardization. It will use evidence-based program to standardize the procedure. Then we move on to advanced care planning. Is how it should be done. This one is an ongoing process. It's not something that we do only once. It's an ongoing process for each patient. And again, it should be reviewed and be updated regularly. For instance, in the case of the appointment of the decision maker, maybe we can ask the patient that if the person he or she appointed, is he still the person he wants to make decision for him in case he cannot communicate to what he wants to happen to him or her. And it will integrate into routine patient-centered preventive care. And it should be appropriate done according to standards. And it should be staged to individual state of health. Then we'll move on to what to consider in advanced care planning. On assessment of the individual need, we need to consider the individual need when asking the patient. Then in the life-changing events, e.g. death of a spouse, I think we follow new diagnosis of life-limiting condition. And again, multiple hospital admission. And then lastly, on admission in a healthcare facility. This is what we have to consider when doing the advanced care planning for our patients. Then we move on. When we should not attempt doing the advanced care planning for our patient. This is when the patient lacks capacity to make decision. In case when he has to make decision on who will make decision on his behalf. So if the patient cannot make decision, then we should not go ahead with an advanced care planning. When the level of stress are high, then advanced care planning should be put on hold. When the patient gives verbal or non-verbal cues that they are not willing to engage, then that's when again we need to put on hold. And then here we're coming to the benefits of advanced care planning. The advanced care planning, it improves the patient's care. Secondly, it provides specific guidance in making clinical decisions as the patients live with advanced illnesses. And again, it provides population health. and it decreases moral distress and decreases conflicts. It shifts time spent on crisis management into a patient wishes or decision. A high perceived family satisfaction and less stress and anxiety for family members. And this was my last slide. I can welcome questions if there are any. We can also use the chat box if there are any questions. Thank you very much. I will go back to Mr. Kambule Sebenele to facilitate the questions if there are any.
Thank you so much, Mr. Mabuza, for the lovely presentation. I hope he was audible and it was an informative presentation. Well, what I picked from the presentation is that it is important for healthcare workers to discuss, record, and honor clients' choices about their end-of-life care. And also, it is important for a client to identify and for the healthcare workers to identify the pros decision maker as someone who's appointed by the client. And also that advanced care planning should be reviewed and updated regularly. And also that one of the benefits were that it decreases moral distress and the clients, it also decreases the conflicts. May I welcome those who have just joined us, and I will kindly ask them to introduce themselves in the chat box, and also to make sure that their phones are on silence and their devices are muted so that there are no interactions. So at this point in time, I will ask for, if ever you have a question to ask, this is your time. If you have a comment, and if you have a recommendation or addition based on the presentation that we had, I will give you this moment to you. Feel free to say anything. We're here to learn, and we are happy to have you. So this is your moment. Yes, colleagues, feel free to write your comment on the chat box. And if ever you want to say something, you can raise your hand or just, whether it's a question or a recommendation, we're happy to hear what you're about to say. And I'm sure the team from RFM, maybe they have something to say. We'd love to hear what they can say about the presentation that we have heard from Mr. Mabuza. Okay, we do have someone that wants to say something. Go ahead, Mercy.
Thank you, Sebenele. Good afternoon, colleagues. My name is Mercy Shabamo. I have a question. Unfortunately, I can't recall which slide it was, but I think it was talking about when is the appropriate time to do advanced care planning. I'm not sure if we can be able to share that screen.
What's the question?
Okay, thank you, colleagues. Thank you, Mercy, for the question. So we're still checking on the slide. The question was when was it the appropriate time?
Okay, there's a point that mentioned that it's proper to consider advanced care planning when a spouse, when there's life events that change. So I was hoping that our presenter or the IMPACT team could elaborate a bit on that so that we can have a better understanding.
Okay, thank you for the question. I will ask Mr. Mabuza to say something on that. Or anyone. Okay.
No. Yes. Yes, you can.
Yes, so my question is that looking at the slide, when to consider advanced care plans, there's that bullet point number 3 where it says life-changing events, for example, death of a spouse. I was hoping that our presenter or the ECHO team can actually elaborate on that and explain what it really is about.
Okay. Normally what happens, colleagues, thank you so much for attending. Advanced care directives normally advise that should be initiated or be commenced while the person is still alive. But there are cues or there are events that we can build on to stimulate or to facilitate such conversation to people who are still alive. So that's bulletin saying a life-changing event. If we have a client in our facility that was admitted, for example, and then unfortunately they died, then that's a good platform also for the healthcare providers to engage the family members on issues of setting up an advanced care plan for their own lives now. For this example, the point was saying when there is a death of a spouse. So when we have lost a loved one, that's a good ground for the healthcare team to then open the eyes to the relative or the alive client on it is very important that in life we need to have advanced care directives. Let me say if maybe we have dilemmas or there were conflicts on how the patient could be cared for before she died or he died, then the relatives of that patient can then be engaged on the solution for lifetime. But such problems can be solved if we can have advanced care directives, and then that's how we can introduce them. So that's when the point says, when can we consider initiating them? So when they're saying, when there's a death of a spouse, we can initiate them. We need to understand that advanced care directives are not for sick people. They are not only for people who are now approaching death, but they are for every one of us. As we understand in our local context, most of us we have various schemes. It's because it's an advanced care directive that, okay, when I die, I want to be buried by a Duke's insurance. So even advanced care directives there, they say, if then a situation comes when I'm not in a capacity to make my own decisions concerning my care or the treatment that I need to be given, I have this legal document that I've set up, or I have compiled this list of my wishes and the wishes that I don't want and the things that I want, the people that I want to be there in my care and the people that I don't want. So I have tabled it, it's signed, it is there, so I can present it. So someday will come with it in the form of a living will. And then as a facility, we have to sit down and find a way on how we can help our clients who don't have the will to make an advanced care statement so that we can avoid such dilemmas. Thank you, Mercy, for the question.
Thank you, Mr. Masham.
Thank you so much, Mercy, for the question. And thank you, Mr. Mahlang, for your elaboration on this question. Feel free to use the chat box to ask and to make your own recommendations and additions on the presentation. Okay. Okay, we have a hand. Please feel free to please unmute and say what you have to say.
Good day, colleagues. I hope everyone is well. It's a pity that I just joined, but I wanted to comment on what Mr. Masangu was speaking on, and I think that is very ideal. But Ukanzauti, most of the time, culturally, to even talk about death in front of the family or even with the relatives or even with the patient that is not well, it becomes a problem. Maybe now you are actually saying this person is going to think, even though they're now in the palliative stage. So I don't know. I think it's a question, and at the end of life, they don't want to talk about death, or maybe we are not trained enough to be brave to actually engage them on the topic. I think theoretically what Sandile is saying is it's perfect. In fact, I feel like we fall short in actually making the plans for the patient properly to avoid disputes even after the patient has passed on. So I don't know how we can tackle that one, the cultural barrier, or I don't know what to call it. Even in the hospital, I work in the chemo department mostly. Can you guys hear me? Hello?
Please go ahead.
Oh, yeah, okay. So I work with most patients really about the end of life. So you find that even the staging, they never tell them that, okay, no, now you're in stage 4, or they don't tell them that, no, they just have this thing of being in denial, or I don't know how to put it, but I'm just saying culturally it's still impossible for us to actually just engage them properly on this. On the example that Sandile was making. Thank you. I think I'm done, yeah.
Thank you so much with that. Thank you for the comments. Yes, I think there is the gap there, which we need to be looked on. Still a gap from our health sector. Mr. Mabuza has got something to say. Go ahead, Mr. Mabuza.
Thank you very much, Mr. Seven and Simpiwe. No, it's a very critical area, Simpiwe, especially in our settings. It is very difficult to talk about this thing, but I think I can bring something up here of interest in the slide, the segment to consider. The 4 bullets. Even then, when the person is diagnosed, then even then it becomes even difficult too. But I think it's when we can try and engage before the patient reach the end of life stage. Maybe we can try and engage there at the early stage of the diagnosis. Though some of our patients in our setting, they are diagnosed very late. Some is at stage 4, so it's a very big challenge. You are right, it's a very big challenge. But then there's a following bullet which says multiple hospital admission. I think if we can maybe try in the multiple hospital admission, because most of our patients before they are diagnosed with cancer, they have some multiple hospital admission. Maybe if we can, even without the life-limiting condition diagnosis, even if it's before it's revealed, there are these multiple hospital admission. I think maybe we can try and drop in there and try to talk about it. So I think it's one other way that could lessen the burden on our side of talking about these advanced care directives, because mostly it involves what happens if you can't do something. When you tell a patient that there's a certain time that you can't do something or you can't talk, the patient becomes scared. So, but I think before the diagnosis, if the multiple hospital admission, I think then maybe we can have a chance. Even at the clinic, in our clinics, there are these patients who come in now and then. I think that's another clue that maybe I need to discuss a advanced care directive with this patient keep coming with this condition that are similar to life-threatening condition. So I think maybe if we can try in the multiple hospital admission, we can find something that's positive. Because when you are right on the hospitalization of our patients, it becomes even difficult even to explain to the relatives. Thank you very much. I'll give it to 7.
Thank you so much, Mr. Mabuza. Yes, there is a question from Nantsigelelo on the chat box. Can we clarify on the DMR orders under advanced care?
Okay, thank you, Nantsigelelo. Did you mean DNAR or DNR? Yes.
Okay, thank you so much, colleagues. Yes, no, Sigelelo, we have noted your question, and I think we'll tackle it as we gonna look at the case presentation from your side. Well, thank you so much, colleagues. I will also emphasize that it is important for healthcare workers to discuss, to record and honor clients' choices about end of life, and to identify the appropriate decision makers for clients, as well as making sure that the advanced care planning is being reviewed and updated regularly. So in the interest of time, okay, I will also ask if ever you've got a question, continue to write on the chat box, feel free. This is our platform to learn. At this point in time, I will kindly ask Nonsigelelo and RFM team to present their case. Thank you. Nonsigelelo, are you there? Are you able to present the case?
Hello.
Yes, Nonsigelelo.
Yes, I will, but the network here, it's not convincing, but I will try.
Okay.
Yeah.
I have given you the co-host access. You can try once. In case you are not able to share it, please let me know. I'll share my screen, or Sandile will share the screen from his end if possible.
Oh, okay.
Nonsigelelo.
Yes, I will share.
Okay. Nonsigelelo, are you able to share the screen? Nonsigelelo, are you able to share the screen?
Yes, I'm trying to share.
We can see your screen. If you can kindly pull up the case. Right now we can see the Zoom window.
Opening.
Okay.
Can you see the slide?
Yes, we can see that, but not the case.
Hello.
Yes, can you open the folder with the case and open the case itself? Now we have opened multiple windows, so may you open? She's lost.
May we give her a few minutes? I think the network is down. We'll try to communicate with her. Thank you. Okay,
Would
thank
you
you.
like me to share the screen?
Okay, okay. Yes, thank you so much. We have noted a question from the chat box from Kindile Nkambule. If possible, I would like to ask Pindile to elaborate on the question. Yes, the question is, I'm still not sure whether the risk involved in taking into consideration. We just want to find out, okay, clarity on what risk. Thank you. Okay, thank you so much. Yes, if Pindile are still there, I'd like you to elaborate on your question. You can just write on the chat box or feel free to unmute so that we can have the clarity. Thank you. Okay, sorry, colleagues. It seems like we had network problems with our presenters from RFM Hospital. We're still trying to get hold of them, but it seems like we are failing. Can we kindly just give them 2 minutes, then we'll proceed. Thank you.
Mr. Sandele, in case this presenter is facing some major issues and is not able to join, may I please suggest if you can take up the case on behalf of that presenter?
Thank you so much, Alina. I've just reached here. I think in a minute she'll be in now. So after a minute, Adela will continue.
Okay, sure, sure. In case the problem persists, you may take the case.
Thank you. Thank you.
Okay, thank you so much, colleagues. We really apologize for the disturbance. We're still trying to get hold of Nonsigelelo for RFM to present the case, but in the interest of time, we will present the case ourselves. We hope he will join us maybe later, and if ever we have question, we will ask. So I will kindly ask Mr. Matlam to present the case for us on behalf of the RFM Palliative Care team. Thank you.
Thank you so much, team. This is a case from Relief Fit King Memorial Hospital RFM Palliative Care Unit. This case is a new case. A 56-year-old male with hypertension, diabetes with right and ring on the right leg. The patient has reached an end stage of disease and presented with severe pain on the leg, on the right foot, and that is a gangrenous. Patient refused to amputate the right leg after he was amputated above knee on left leg without his consent. He is ready to die with his remaining leg. He needs pain medication to be with his close family members. The patient is complaining of severe pain. The patient is complaining of severe pain on the whole right foot that is gangrenous since the beginning of January 2022. Is a non-hypertensive and diabetic client on the treatment since 2020, initiated on morphine November 2021, on pain medication, antihypertensives and anti-diabetics. Sometimes he rehydrates and does wound care. He is also having psychosocial counseling. The patient was involved in an accident 2019 and sustained a small laceration on the left leg, which developed into a bigger septic wound that later required an amputation of the leg. The patient was not willing to amputate. Year 2020, he was found to be having diabetes and was initiated to treatment. Was initiated to treatment November 2021. His family tricked him into doing an amputation and was done above knee where he was not expecting it. He was admitted for the whole month of December after amputation and was promised to be well after doing the procedure. He was found to have nerve paralysis. He was also initiated on antihypertensive and morphine during hospitalization. January 2022, a blister-like ulcer developed on the right leg with extended up towards right knee and has become gangrenous. The condition made the client to be bitter and depressed. He started counseling and he informed his counselor that he did not want to be amputated, and he is also not willing to do it on the remaining right leg. He prefers to die with his remaining right leg. After a few numbers of counseling sessions, he then came to RFM palliative care unit to be enrolled onto palliative care on the 23rd of February 2022. He was seen by the nurse and doctor, who also explained the need of the amputation, but the patient autonomously rejected the offer. Medications in the past, the patient was on metformin 500 POBD, and then was also taking traditional herbs. Current medication involves morphine 30 milligram POBD, paracetamol gram, POTDS, and bisacodyl 5 milligram POOD. Is also on HCTZ 25 milligram POOD and metformin 850 POBD, and he also currently is clozapine 500 milligram PO for 6 hourly, and then is also in dialine 5 milligram POBD. And the social history, the patient is fully compensated and is a soldier, and he has completed his high school, and the social economic class is a middle class patient, and is married with no harmful habits noted, and there are no and there's no history or relevant condition in the family. And then on the advanced care directives, the patient has the advanced care directives for do not resuscitate and intubate orders, and the patient has a living will, and the patient has provided an advanced care decision to refuse treatment, and the patient has a proxy decision maker, whom he said is the family, which involves his wife and kids, to make a decision concerning his health care. His mental capacity was assessed, and the comments and concerns that we have here are any health decision made for the patient must be discussed in the family meeting. So there's nothing else you can do without getting the family meeting. So on the review of systems, our vital sign shows that the patient has an increased temperature at 38 degrees Celsius, and there's a normal BP of 105 or 78 milligram per mercury, and there's a pulse of 110 beats per minute, and respiration is at 28. And then the SpO2 is 96%. Patient complaint of severe pain, which is a score of 10 out of 10, and the patient is confined to bed. So most of the time it's ECOG 3. So most of the time it's on this bed. On the symptom scores, the pain is severe and has moderate dyspnea, and has severe anxiety and agitation, drowsiness and anorexia, and is already poor mobility. And the patient has a moderate depression and moderate nausea, but severe constipation. On the investigations done, the CBC always is above normal ranges, and the patient is HIV negative. And random blood sugar, it was 21 millimole, it was fluctuating most of the time, so it's very high. There are no image done. So the plan of care here, the patient has met with the relatives and close family members to discuss the end of life. As autonomous as he is, he opted to die with his remaining right leg, since the other amputated leg could not help him to be well. He partly blames doing amputation without his consent, yet he was still sane. He called a meeting with his family and allocated resources to his wife, children, and siblings. He still hopes that God can make a miracle. His wish is to be pain-free in all aspects. He is on home-based care and sometimes do rehydration and wood dressing. Psychosocial counseling is still in progress, and the patient will come to visit the hospital for a refill of pain medication, anti-hypertensives and anti-diabetics. Thank you so much. That's the case from RFM speaker.
Well, thank you so much, Mr. Mahlangu, for the presentation. It was supposed to be presented by the RFM team, but due to network problems, we had to present it ourselves. But I'm happy that they are back now. At this point in time, I would kindly ask if ever you have a question, a comment, or recommendation, you can use it, the chat box. Also, you can raise your hand and feel free to unmute yourself and say whatever you want to say. This is our platform. We're all here to learn, and we appreciate when something is being said because we want to improve the quality of life for our patients out there based on the topic that we are talking about today. I will give you this platform, colleagues, to say anything you want to say about the case. I think Nonsigele will be ready to answer some of the questions that we have to say. And if ever there are additions, feel free to say anything. This is your platform, colleagues. Okay, I can see a hand. Pindi Lengambule. Please unmute yourself and say whatever you want to say. Thank you.
Thank you very much, Tim. Can you hear me? Hello?
We can hear you, Pindile.
Okay. Thank you very much. It's just a concern about the patient. I'm just worried because now we have a 56-year-old who has dependents, who is now having signs of septicemia, in severe pain, dyspneic with anxiety, who is still struggling to accept the reasons why the relatives decided to make a choice of amputating him. And I'm worried that as a team, it means we still have a lot of work to do on psychosocial aspect of counseling for both the family and the patient. Because now he's looking at and he's actually having the feeling of dying with his own leg, yet the leg now is a source of infection. And as relatives, there's just no one who can be happy seeing your father or your husband suffering because of the pain, and seeing that gangrene, when I'm talking about gangrene, it means the smell. I'm just worried. He's also thinking that he needs to, as a team, we are also focusing on him having a pain-free life. But with this gangrene, it becomes very difficult for us to reach some of our goals. I think we still need to have a lot of psychosocial counseling to both the patient and the relatives and the whole family. Thank you. Thank you.
Thank you so much, Pindile. Thank you so much for the concern that you have just brought. I think there is something similar with the case that was presented, because in the case, the patient was also amputated against his will. So I think it's almost similar in terms of what was done compared to the case that you have just raised. Well, I will kindly ask Nzigi to say something concerning what you have just said, and also to the case.
Thank you very much, colleagues, for listening to our case presentation. We acknowledge the concern that colleague Pindile Ngambule has forwarded. We will try to assess the need of psychosocial counseling from our patients, and then strengthen it so that the patients can benefit, and even their families and those close individuals or loved ones should also benefit too. Thank you.
Okay, thank you so much, Ziggy. I see a hand from Skulda. Please feel free to unmute yourself and say whatever you want to say. Thank you, colleague.
Thank you so much. Unfortunately, I'm running out of battery. Before my phone kicked me out, I wanted to just find out if the patient was ever referred to Diabetic Swaziland, because I find that sometimes if you meet people that are in a similar situation or are going through the same thing, it's different from maybe a healthcare facilitator or a nurse just telling you that this is what you have to do, but meeting people that are in the same situation, because I think they have a support group. So sometimes when patients cannot accept certain things, if they see people that are going through the same thing, or they now cut off their legs, but they still living, it gives the patient hope. I've seen this a lot with my patients at the hospital. I'll make an example of, unfortunately, I think you guys discussed this case, Angel, but I wasn't part of this yet. But yes, she had no hope whatsoever until she met another child who was also going through something similar, and then that helped her with acceptance and all of the things. So my suggestion was just maybe a support group of sorts for the patients, suggesting Diabetes Swaziland, because I think they already have a support group of sorts. I don't know how the patient can be engaged on this.
Okay, thank you so much, Guta, for the recommendation. We're so much grateful. And thank you so much, colleagues, for the active participation. It motivates us a lot, as this is our platform to learn. I don't know whether Nzigi, do you have something to say?
Oh, okay. Thank you so much, Skudla. Okay. We appreciate your your suggestion, but sometimes other clients are not comfortable joining a support group because their confidentiality will be compromised. Sometimes we don't want to force them. It's a good recommendation, but to some clients it doesn't work for them because they don't want to be exposed. Thank you.
Yes, that's why I was asking if it was ever suggested to him or he refused the suggestion. I'm just trying to find out because I've seen it with a lot of difficult clients it works, but I understand what you're saying. We cannot force patients to do anything.
I can't hear you well. Sorry.
And yes, I'm saying my initial question was, did you guys try that route? Not that you should or depending on the patient, but I'm just trying to find out if it was a route that you guys explored. I'm saying that I've had like success with most of my difficult clients when it comes to that, when they now meet with people that are going through something similar, because with support groups, of course, confidentiality is still within that whole setting, depending on who's facilitating it. I was just trying to find out if you guys have explored that route.
Oh, okay. So far, we don't have a support group in our facility. Some nurse who was also working here tried to initiate that, but some clients were not willing because of their confidentiality would be compromised and other reasons. Maybe we will look at it again and try to initiate it and try to recommend it on patients for their benefits. I think you well answered, Skula.
Yes, thank you. Thank you.
Hello. Yeah.
Yes, thank you. You have answered it.
Thank you so much, colleagues. Thank you so much. Well, okay, it's a recommendation from Pindile Ngambule. Says there is a need for multidisciplinary team as we have uncontrolled sugars. Thank you so much. We appreciate the contributions, colleagues. Pindile, do you have something to say? I see your hand is raised, or it was just the previous hand. Pindile, are you there?
Oh, my hand. Thank you. I forgot to take down my hand. Sorry.
Okay. Thank you so much. Thank you so much, colleagues. It is very important for us healthcare workers to discuss about the client's advanced care and to honor the wishes of the client. So at this point in time, I would kindly ask if there is anything my team would like to add on or ask as well. Yes, Mr. Mabuza has got something to say. I will please take
take over, Mr. Mabuza. Okay, thank you, colleagues. Thank you very much. I've noticed something during the case presentation that, and it was discussed here as a question also, that the patient was amputated without his consent or wish, and it was the family members who advocated for the amputation. But now the patient is refusing to amputate the other leg because previously he was amputated unwillingly. So now I'm getting to a point now that the patient is suffering because of the family members' decision. So I think in the slides when I was presenting this, it's marked in red. The patient's right to refuse the treatment. I think there is something that we can take into consideration as this now is affecting the patient. Because the amputation can relieve the patient from pain, all know that, but now the patient has to take pain medication because he's refusing to amputate the leg and he's angry that before he was amputated without. I think maybe before all these things, we need to consider the patient's wishes. Is the patient does really want the procedure or not before engaging the family members? Thank you very much.
Thank you so much, Mr. Mabuza. Thank you so much. We really appreciate the contribution. I think we're left with a few minutes, but I'll still open. If ever there's someone to say something, feel free to indicate and to write or ask on the chat box. I'll also kindly request you, colleagues, to enter the link on feedback. The link is on the chat box, where you will share your feedback, because you would like to know how you feel about the session and where we can do better as a team. Yes, colleagues.
Thank you so much, team. Thank you so much, colleagues, for such a wonderful presentation and such a wonderful case. Indeed, this is a case that we need to put into consideration, and these are the ethical dilemmas that we usually find ourselves in. Sometimes we feel like I will be pushing the patient or relatives to decide this, and then I'm causing more harm. I'm doing this. But one thing we need to understand that are the 4 basic principles of ethics that we discussed in few previous presentations, that there's autonomy, beneficence, malfeasance, and justice. We need to put those ones and embrace them in our activities while we are taking care of our patients. In this case scenario, I would recommend and encourage RFM and say thank you so much to do the greatest work, also to listen to what the patient is saying. And I think the mistake that was done before to this patient has caused us a lot as a healthcare team, because now the patient cannot consent to another treatment based on what was done initially. I'm so happy to see the case coming with the do not resuscitate, do not intubate orders being done. I think RFM can have good experience to share with us. Our next presentation will be on withdrawal, and which will be on intubation or feeding and hydration. I think you will help us a lot. How do you go about to have advanced care directives in terms of do not resuscitate and do not intubate orders. And also the issue of a living will, that it was great to inquire about it, and it was helpful if the patient already had it, or if you allowed them to draft it down so that they can have it. And also to ascertain the issues of advanced care treatment. And that one, the issue of advanced care decision to refuse treatment, it's legally binding and shall not at any point be overridden by anyone. So it's very important to adhere to that. In fact, it reduces the conflicts and dilemmas among the health team. Even if the doctors and nurses will feel that this treatment will work for the patient, and the relevant family say it will work, but if the patient continue to say, I do not want this treatment, we don't have any guts to continue. So in such a situation, we need to continue with that. Even if the patient will decide on things that are totally against our plans and our knowledge or our beliefs, even the family beliefs, whatever the patient says she wants in terms of care, it is for the patient, unless it is legally and ethically not. For example, if a patient say, give me a lethal drug so I can die, legally and ethically, we are not allowed to do that. So I can say it was a great case, but let's continue to embrace these advanced care directives in our facilities. Let's not engage them when they are already admitted to the ward. Let's start them in the OPD. Let's engage our team, let our colleagues and our administration to, if the administration files do not include such statements, let them be there so that we can prevent the harm and promote comfort and promote quality of life of our patients, not imposing our medical expertise, but helping them to cope as well as having the best that they can. I'm happy that the patient is still able to get morphine and other medication that can help the patient to continue. That's great for Nazarene. So we are so happy for you to see that happening. I'm hoping all of us are learning something out of it, and I'm hoping you have also learned it. But with the issue of support groups, it is one of the pillars that supports our palliative care patients when they are linked to support group. But that one must initially discuss, as we have said and recommended, and the patient consent. So we need to establish all those things. And the spirituality of the patient, I would recommend that we build on the spirituality of the patient at this time around, so the patient can be well built, and even the family members should be well built. And with the issue of family meeting, I feel like at that point, we also need to sit down with the family and find the decision maker, because we know the family dynamics. Always in a family, there's always a decision maker there. And culturally, in our country, there's always a decision. So I would think as a RFM palliative care unit, it will help you to know who will be the decision maker in these situations. Because if the patient can say my family, but the reality is when the patient says family, he's referring to a certain number of people or a certain individual. So I would recommend that we do get the family itself, who is the family decision maker, so that you may know that if a certain decision has not been made, was that decision maker involved. I was happy to see that the man has already planned his will, where in terms of dealing with the resources that he has and his allocation to the family members in case of death, with the spiritual that saying, I'm still hoping for the best. That was great. And I think advanced care directives are not a one-day thing. They are continually being renewed now and then. So it's very great that every time the patient do a visit to your facility, or you have linked him or to a home-based unit like hospice at home to visit them at home, kindly do the continuous assessment of the advanced care if the patient is still continuing with the same advanced care directives as made initially, so that can be updated in his or his file. I think that's what I can have as my recommendations for this case. Without maybe going back a lot and then say we will have our next session on the 23rd of March 2022 at the same time 1300. We are still looking at the ethical dilemma that affects us as healthcare workers while we are taking care of our patients, especially those people with life-threatening and life-limiting conditions. So we'll be looking at, in our next session, we'll be looking at an ethical dilemma on artificial hydration and nutrition. When should we stop artificial hydration? When should we continue? We'll be looking at that dilemma so that we can know how to deal with it as healthcare workers in this issue of ethics. So we'll be looking at that on the 23rd. So to be part of the session, a feedback link has been shared on the chat box. You are encouraged to click it. And then when you are going to get the materials for the session, and the feedback link also will be shared through an email. And also a registration link for the coming session will be shared. We encourage you to be part of this session and invite other people, because we understand as healthcare workers that we need to be all capacitated so we can do one and the same thing with one goal, making our patients have the best care they can, and also relieve the load that we are also facing. So we are free to call me or call Hospice at home on 7629-7140 or WhatsApp at 79297140, or email me at sandile@eswatinihospital.com for any questions or clarities or concerning the project or participating or registration. So if ever a colleague wants to be part of these sessions, is encouraged to share his information with us so that we can upload his name into the links that we have for suited smooth running. Thank you so much for me. May I hand over to Msutu. Thank you.
Thank you so much, Mr. Matlangu, for the recommendation. Thank you so much, colleagues. This brings us to the end of our session for today. I just want to say thank you so much for the active participation. I hope it was of great benefit to everyone. Yes, it's the end. Have a lovely afternoon and enjoy the rest of the day. Goodbye, colleagues.
Bye-bye.
Bye-bye.
Okay.